Hello, I'm Dr. Banu Arun, and on behalf of CME Outfitters, I would like to welcome you to today's educational activity titled Tackling Barriers to Genomic and Biomarker Testing in Precision Cancer Medicine, Integrating the Latest Evidence into Practice for Community Oncology Clinicians. In this episode, we will be discussing the interpretation of genetic and biomarker testing results. Today's program is supported by an educational grant from Merck, Sharp, and Doe. Now, let me introduce your faculty. Well, I am Banu Arun, professor at the Department of Breast Medical Oncology, co-medical director of clinical cancer genetics at the University of Texas MD Anderson Cancer Center. Joining me today is Dr. Robert Coleman, gynecology oncologist, chief medical officer at the Sarah Cannon Research Institute, co-director of the GOG Partners, Philadelphia, Pennsylvania. Welcome, Dr. Coleman.
It's so nice to be with you. Thanks for the invitation.
Sure. So let's start by reviewing our learning objectives first for today's session. After participating in today's activity, participants should be better able to interpret results of genetic and biomarker tests to better inform and target therapies for our patients. So let's get started. In our previous sessions, we've had a lot about biomarkers, and today we are going to be talking about how biomarkers are actually used to guide clinical decisions. There are two kinds of biomarkers that we use. Rob, would you like to share with us what we mean by prognostic and predictive biomarkers?
Absolutely. And it's great that we get a chance to talk about this because it's a topic that even in today's medical literature, you see used kind of interchangeably, even though they really mean something very different. So, for the most part, we talk about predictive and prognostic biomarkers, and many people are familiar with prognostic biomarkers being those types of biomarkers that kind of reflect the outcome in a population. It's almost irrespective of therapy. So it's just that in the presence of a biomarker, there is either a good or a kind of a not good outcome that we might expect to see. And we have lots of examples of prognostic biomarkers. In fact, in most textbooks, if you read like the first etiology page, you'll see a whole list of prognostic biomarkers that don't necessarily implicate the disease, but they give us some idea about what types of variables might influence outcomes that we might see in a clinical trial. So these particular types of biomarkers are super important to understand well, because when we design a trial, let's say comparing a therapy 1 versus a therapy 2, and we don't control for these prognostic biomarkers, we may end up with a spurious result. So a good example might be, for instance, PSA level at the time of prostate cancer diagnosis, or a PIK3CA mutation in HER2 positive metastatic breast cancer, and an ovarian cancer. And let's give you a surgical example. Patients that present with who are post-operatively left with bulky disease, as opposed to those that are left with less bulky disease, have a different prognosis. So volume of post-op residual is a kind of a prognostic biomarker. And so when we look at these analytically, if we were to look at the difference between, let's say, an experimental therapy and a control group, that hazard ratio that describes the difference between those two therapeutic variables would be the same if we were to look at them under these two conditions of a prognostic biomarker, but the curves would change. So the control arm in one situation would be different than the control arm in the other situation, because the biomarker has a prognostic implication. And that really needs to be very much distinguished from predictive biomarkers. And that's exactly what it sounds like. If you have the biomarker, it predicts that you're either going to do better or worse, usually in the context of a therapy. And so a pure predictive biomarker would be the situation where that if you had, let's say, a drug that was related to its efficacy related to the presence or absence of that biomarker, the only group that you would expect to see a impact of therapy would be in the patient who had the biomarker and got the therapy. So everybody else, including the control patients in the absence or presence of the biomarker, would all line up to be exactly the same. So relative to the previous example, in this situation, the hazard ratio in the experimental arm in the presence or absence of the biomarker would be very large. We'd hope it'd be huge. but the hazard ratio in the control arms and the biomarker negative groups would be essentially the same, or the medians would be essentially the same. So this is a pure example of a predictive biomarker. And there's a few examples of these. There's not so many because frequently the predictive biomarkers also has prognostic implication because it usually reflects biology. But there are a few examples of that. And, one might be the use like of a ERBB2 inhibitor like erlotinib in advanced non-small cell lung cancer, where we see this this effect in the patients who had the mutation, or as we might see with an early stage HER2 positive breast cancer with or without the exposure to trastuzumab. So there are some good examples of where this kind of exists. So if you put these together, what you have are these independent functions that are super critical to understand well, because when we design trials, we have to account for the kind of the control arm efficacy or control arm impact of the biomarker, and then also the predictive part of that biomarker with respect to the therapy that we're investigating. And so, as I mentioned, for many, many situations, the biomarker, let's say BRCA status or BRCA mutation status, actually has both. It is a prognostic factor and it's a predictive factor for instance, for PARP inhibitors.
Yeah, thank you, Rob. So, this introduction is very helpful, and it really leads into my next question. Where are we with implementing biomarker analyses to guide therapy in the community setting? Are we doing optimal?
It's a good question. I think for me, it's always something that we need to continue to strive because, to get a new drug across the finish line, we really have to demonstrate really profound efficacy, better than available therapy. And so sometimes, adding, an agent that has only marginal benefit, is going to be hard to distinguish against the background noise unless you do a gigantic study, thousands of patients. So what we'd really like to do, we'd like to be able to have the situation where we have a biomarker that can describe in this situation, a predictive biomarker that can describe the efficacy of a new drug, because that allows us to drop the sample size of the trial and demonstrate a more clinically meaningful impact of a difference between the patients who had the biomarker and got the new therapy versus those that didn't. So it's really important that that we, incorporate these, look for biomarkers, and it helps us to, on the negative, it helps us to not expose patients to therapy that isn't going to work for them. So it has both a positive and a negative potential impact on guiding precise therapy, which is ultimately what we want to do.
Wonderful, thank you. So what are the mutation testing options? What type of infrastructure or platforms are out there?
Yeah, and this continues to be, to expand, and it's a space that's really rapidly growing. I think traditionally we have relied on mutation evaluation or mutational analysis, and these can be done, looking at the whole genome. It generally will return, analyses on 500 or so genes, some of which are undruggable, some of which have no prognostic value, some of which are co-related, or they're actually not related to tumor biology at all. So there's a lot of these alterations. Just kind of depends on the tumor type that we're looking at. I think as we've seen this nicely presented in, for instance, in lung cancer, where new therapies that are related to the existence of these predictive biomarkers like ALK fusions, ROS1, RET, MET, EGFR, these specific mutations now can be lumped into these panels, so they can be turned around relatively rapidly to help clinicians, come up with a decision for therapy in a timely manner, so that patients don't have to, wait. And then there are, it's important, since many of these somatic mutations that we see can be coming from an inherited mutation. And so it's important that if this is an associated heritable situation, like we see with BRCA mutation, that we have an opportunity to assess for germline, because that obviously will have a lot of counseling potential, and even interventional strategies for preventative interventional strategies. But this world is continuing to change. Now we have RNA tests, and we have ability to do this in blood. And there's, this, the precision by which these are being done, and the availability of not having to rely just on tumor tissue it has really expanded the space and given us a lot of new opportunities.
Right, because otherwise we have to keep biopsying patients, right?
Yeah.
I think it's kind of the gold rule to biopsy the first metastatic lesion that's what we all learned during our fellowship. But now with all of these, technologies and new targeted agents, we do more frequent biopsies in a metastatic setting. So a liquid biopsy analysis is really very, very helpful. To continue on this, what type of tests are available? There is microsatellite instability and mismatch repair deficiency evaluations, and that is sometimes confusing. Can you walk us through the significance of MSI and MMR in cancer?
Yeah, well, they kind of relate to the same kind of thing. One is obviously looking at protein, and the other one is looking at the specific microsatellites. And there's lots of different ways to do that kind of testing. But for instance, in several tumors that relate to this, like colorectal cancer and endometrial cancer, it's important for us to have at least one of these modalities available to us. Fortunately, what we see is that there's high correlation between MMR status based on these proteins and MSI status based on PCR evaluation. But we've also learned that there's an opportunity to actually test for mutation in the genes that drive the ability to fix microsatellites when they occur in the DNA. So this is, fortunately, this is becoming more routine. I think most of our endometrial cancer patients are getting, if they're endometrioid, are getting MMR testing right from the pathologist right away. So we get to know this information right away, and it's becoming increasingly important to know that information as we do our treatment planning. But we do have these two techniques, and in some tumor types there are some different variables that we might want to evaluate. One of the key components for understanding this particular feature of cancer is that the inability to repair these microsatellites leads to a high level of tumor-specific neoantigens, and they're frequently associated with high tumor mutational burden. And of course, these are two really important features that drive what we hope would be the efficacy of immunotherapy. And we've seen that as we'll talk a little bit about drugs, that have been approved under these conditions, the initial indications for these immune checkpoint inhibitors to make their way into endometrial cancer and other tumors really came from a pan-tumor evaluation for microsatellite unstable or tumors. And so even though there may be some variances across these different tumors, they are typically associated with these high tumor mutation burdens. And if we look even deeper into the actual proteins or the genes that we're trying to evaluate, some of those genes have a higher probability of producing high TMB levels and higher levels of tumor-specific neoantigens. So those are, hopefully these will translate into better description of therapy, targeted to this particular immune active or hot tumor kind of microenvironment. So so a lot of people say, well, how do you test for it? And so there are a couple, as I mentioned, there are a couple of ways that we can do it. One is to actually check for the microsatellites themselves. As I mentioned, that's a PCR based test that has a relatively high rate of sensitivity and specificity. We can also test for, as I mentioned before, the proteins, loss of this protein expression. And then again, as the build out has happened with the next gen sequencing and the availability, we're starting to see looking for actual mutations in those genes that are driving these alterations. In general, they all basically kind of fall in the same, performance. And, we oftentimes talk about this with respect to specificity and sensitivity, but, and those are the ways that we measure the accuracy of the test when we know what the defect is. In the clinic, you and I will order these tests not knowing what the defect is, right? So we're actually looking for positive predictive value and negative predictive value based on the samples that we send. And fortunately, we see low levels of false positives and false negatives. And so I think overall, we're fairly confident that these are good discriminators for the presence or absence of this specific alteration in the tumor. So, and I see that other people will often say, well, wait a minute, immunotherapy and PD-1, right? That's what happened. We see that in lung cancer. We see that in all these different tumor types. How does that play out in tumor types like what I deal with, like in endometrial cancer? Well, it's interesting because first of all, there's a zillion ways to actually measure PD-L1 status or in the tumors with different antibodies, different cutoff levels. But MSI status, the tumor mutational burden, and PD-L1 expression all relate in different tumor types to the efficacy of immunotherapy. But in endometrial cancer and to some extent in colon cancer, we find that the PD-L1 status is less actually predictive of efficacy for an immune checkpoint inhibitor. The other two seem to have a very good relationship with the predictive nature, looking at efficacy. And so we think that a lot of this is driven by the fact that these tumors that lack this ability to impact the microsatellites lead to these high levels of TMB and high levels of tumor-specific neoantigens. And we can see this in tissue, which is kind of neat. When you look there, you'll see all these immune cells that are infiltrating these particular tumor types. But ultimately, when we look at how they relate to the efficacy of therapy, we find that their tumor types are quite different. And so in colorectal cancer and endometrial cancer, we see a relatively close overlap between the TMB and the microsatellite, the TMB and the neoantigens that we see under those two conditions that are very different than what we see with the PD-L1.
Rob, you mentioned endometrial cancer. Can you expand on that a little bit and give us some examples? How we measure MSI or how we use the measurement of MSI and MMR with some example agents and some chronologic information, how the treatment has changed for endometrial cancer.
Yeah, this is a big win for us. For those of you out there who have treated endometrial cancer patients, know that we hadn't had an approved drug in endometrial cancer for decades, other than hormones. We use chemotherapy, obviously, but we hadn't had an approved drug for a very, very long time. And now that we understand a little bit more about the molecular biology of endometrial cancer, we got very excited to see that the two kind of conditions, one being microsatellite instability and the other being a high tumor mutational burden associated with POLE mutation, that there is an opportunity to take advantage of what I just mentioned. And so, this is another good example of a predictive biomarker that doesn't have prognostic implication. And we learned that in endometrial cancer that there is this cohort of patients, probably maybe as much as 25 to 30%, that carry this alteration for deficiency of the mismatch repair proteins or MSI high status. And as I had mentioned in the initial paper that was published in 2015 in New England Journal of Medicine, they had patients that had endometrial cancer that were given pembrolizumab that carried this MSI high status, and they saw responses. And so this was expanded and ultimately led to an approval for pembrolizumab across a kind of a tumor agnostic indication. Ultimately was also given the indication in MSI endometrial cancer. A second drug called dostarlimab was recently also given that label in endometrial cancer based on a very large phase 2 study called the Garnet trial. And then in between those two, in 2019, we saw the results from Keynote 775, which was looking at the efficacy of lenvatinib and pembrolizumab predominantly in patients who were MSI stable or MSS stable. So these were patients who did not have a tumor that demonstrated mismatch repair deficiency. And what we saw was that this combination of lenvatinib and pembrolizumab was actually more efficacious in every parameter it looked at: PFS, OS, and objective response, and then available chemotherapy. So single agent chemotherapy. So these kind of three conditions, the two indications in MSI high or microsatellite unstable tumors with pembrolizumab, dostarlimab, and then the combination in MMR proficient endometrial cancer led to the availability of these therapies.
Thank you. So now moving on to another exciting area is PARP inhibitors. There is great data, especially for gynecology cancers, but others, including breast as well. And when you review the data, can you lay out again for us the difference between germline and somatic? Because the indications for PARP inhibitors might not be the same for breast and ovarian, for example, related to germline versus somatic.
Yeah, this is a great story, and thank you for your work in this space. I mean, a lot of what we know today is actually from work that you've done, and we're really grateful to having dedicated investigators like yourselves to help us sort out this story. We've known for a long time the relationship of BRCA mutation status, and particularly in the germline, which is carried in a copy in every cell of the body, and its relationship to the development of breast cancer initially, and then also obviously now seeing with breast and ovarian cancer. And in 2005, it was shown in the lab in two separate papers in Nature that tumor cells that lacked homologous recombination proficiency, they had a deficiency in that, mostly driven by BRCA mutation in those cell lines, were exquisitely sensitive to a PARP inhibitor. And so what we think in our concept of this was that the PARP inhibitors were responsible for creating the condition for a double-strand break. And in the absence of having compliant homologous recombination, those cells became lethal, synthetically lethal. So in other words, a PARP inhibitor where homologous recombination is proficient, there we didn't see yet any toxicity. But when it was absent, we saw this like a multiplier effect on a cell kill. And so that was super exciting. And 4 years later, we had our first paper with treating of a PARP inhibitor in patients in the New England Journal of Medicine as a phase 1 trial. So and that included both breast and ovarian cancer patients. We were super excited to see that. And that launched this rapid, extraordinarily rapid development with our first phase 3 appearing in 2012, looking at this drug, this class of drugs, not only as therapy, but also as prevention of progression. Maintenance therapy. And so the kind of our big wins was that we had 3 of these drugs demonstrating efficacy in shrinking tumors in patients with recurrent disease. And then we moved that into kind of a similar type of situation as a maintenance setting after induction chemotherapy. And we have 3 drugs defined by a biomarker, BRCA status, and another related biomarker called homologous recombination deficiency that had a predictive implication even when they were BRCA wild type. So you could have a BRCA wild type and an HRD test positive tumor. And we showed that in the recurrent setting, particularly in patients who were getting maintenance therapy, that these were all positive. And this was, when we saw these data, it was really earth-shattering for us because we'd never seen hazard ratios of less than 0.5 and seen them in the 0.2 range really kind of changed standard of care overnight. And so because that was so positive, we then moved them into the frontline setting, and voila, repeat stories, second burst, same as the first. We showed that across now 6 trials that the incorporation of PARP inhibitors with biomarker positive disease is extraordinarily active and now has redefined the standard of care in the frontline setting. So you mentioned something about somatic versus germline, and I think it's really important to understand the difference between those two. We know that there is a heritable form of this disease that we see in about 15 to 20% ovarian cancer patients, and it's different in different tumor types. And there are different types of founder mutations that are actually passed down, as you know, in these different tumor types. Like it's different pancreas than it is in ovarian cancer, or it's different in one part of the world with ovarian cancer than in another part of the world with ovarian cancer. So we have a lot of variance there, but there is a direct linkage to that. There are tumors, though, that acquire a mutation in the BRCA genes as part of the cancer process. So they may not carry it in all their cells, so they don't carry the heritable part of it, but they carry the absence in the tumor. So functionally, these appear in ovarian cancer to be very much the same. So we've not been able to demonstrate an efficacy difference if it was a somatic acquired mutation or it was inherited and then became mutated, double mutated in the tumor. And so but it's very important because like your life's work is that is to identify these patients who carry this in their germline and that we do the appropriate counseling to, initiate the best healthcare that we can. And I know that you guys have seen this in the breast cancer world too. What's been the experience?
Yeah, I mean, again, we are just thrilled and excited. So we have 3 prospective trials in the metastatic setting for germline BRC positive patients, and then very excitedly, 1 prospective adjuvant trial with PARP inhibitors. So the 3 prospective metastatic trials are the Olympia D, Embraca, and Brocade study, where in the first 2, PARP inhibitors were compared to chemotherapy. The third one, Brocade 3, compared chemotherapy plus a PARP inhibitor, veliparib, to chemotherapy. The studies were actually pretty similar, HER2-negative breast cancer, 2-to-1 randomization, and the primary endpoints were all met in all 3 studies. Progression-free survival was significantly improved. The adjuvant trial, Olympia A, actually randomized germline BRC positive patients to 1 year of maintenance olaparib versus placebo after all patients had completed their chemotherapy if indicated, radiation therapy if indicated, and surgical management as well. And hormonal receptor positive patients could have been on endocrine therapy. And this study also met its primary and secondary endpoints. Invasive disease-free survival with 1 year of maintenance olaparib in the adjuvant setting compared to placebo was improved by about 40%. And a very recent update, which was very recently published by Dr. Geer, also showed for the first time, a 30% improvement in overall survival. So we are very excited about this. And again, it all goes back to, we should not be missing on these patients. When we see our patients, we have to think about all of these new biomarkers and its implications for the treatment, because now it can also save lives.
It's awesome. Yes. So exciting. Yes.
It is. It is. So then let me start wrapping this up. So what we discussed today is, I think a very important point that Dr. Coleman made is the difference between prognostic and predictive biomarkers, the implications and the clinical meaning, and also that I think the best interpretation of results can be done when we have actually normal and tumor paired testing, so germline versus somatic. That's very important. And I want to now mention our SMART goals. The SMART goals include SMART, measurable, attainable, relevant, and timely goals. And they are that ideally we should pair germline with somatic testing wherever possible. We should use consensus terms of biomarker testing and results. And it is a complicated discussion. The topic is complicated even for ourselves when we discuss it, but speak in plain language with the patients about testing results and the implications for the treatment for our patients, and encourage genetic counseling in patients with high suspicion of pathogenic germline mutations. And again, thank you, Dr. Coleman, very much for our discussion. It was very enlightening. And thank you to our audience for joining us today.
Thank you so much for having me. It's great to be here.